Good morning and welcome to our annual GI update. So I'm Shyam Varadarajulu and I'm from the Orlando Digestive Health Institute. So this is our fourth meeting. This group came into existence in January of 2022. So this is our third year. So it's usually a tradition that I provide you an update on what we are doing as an institute, because this institute is existing because of support of all the gastroenterologists from Central Florida community. So this is our group that we have now. We are now a group of 30 gastroenterologists. We still have to expand as the health system network expands, but we have covered pretty much all the subspecialties of medicine. We see about 5,000 patients in our GI clinics each month. We practice out of 6 locations and out of 7 hospitals. Our inpatient and outpatient procedures have steadily increased. We perform about 50,000 outpatient procedures in the hospital, about 35,000 inpatient procedures, and around 10,000 cases in the AECs each year. Our specialties are also now fully staffed. Liver, pancreas, IBD, and motility. We see about 400 patients each month in the clinics. And this is our advanced endoscopy unit where I practice. We performed a little more than 10,000 procedures this year, and we still perform the largest number of EUS procedures in the nation. Our research has progressively increased in productivity. This is our referral base. We draw patients from across the state and from around the neighboring states in the south. If you go to the website, you have our outcomes data, and as you can see, our performance for general gastroenterology is significantly better than the national average, and this is our advanced endoscopy outcomes at the unit that I practice. Most importantly, publications and research is a critical component of DHI. We have published 2 randomized trials, developed several protocols after Orlando, and we just concluded the randomized trial comparing EUS and surgery for gastrojejunostomy, and we are just waiting for patient follow-up regarding quality of life. AI has been integrated into several components of the program, particularly in endoscopic ultrasound. The first clinical trial has been concluded, and the manuscript is in preparation to be submitted sometime next week. This is a group that Mel Wilcox put together called the United States Pancreatic Disease Study Group, and with the intention of doing good quality research. And the first sham control trial comparing EUS and placebo for pain in chronic pancreatitis is currently underway. We are also establishing a shockwave lithotripsy program for chronic pancreatitis. This is going to be integrated within the advanced endoscopy unit where we practice so that we can provide seamless care for our patients. And this will be the only third such setup to be incorporated within a unit within the country. We have started a GI fellowship. Our first batch of fellows started last year. We've matched 2 fellows this year. We have an advanced endoscopy fellowship, primarily overseas trainees come join our training program. And next year we are hoping to have a liver fellowship and subsequently an IBD fellowship. Our conferences continue to perform very well. We draw delegates all the way from New Zealand to every part of this country, representing about 30 different countries. And this is the program that we have. You are here from 20 states today. And this conference is successful because you travel so many miles from 20 states. You're not coming for Disney, but you're taking time out of your families during the holiday season to come and get educated. But the quality of any conference is going to be incumbent on the quality of faculty. Our faculty are some of the very, very best. I always say we have better faculty than DDW or ACG. They are very, very accomplished people who have, during a very difficult time of the year, rather than spend time with family, come to Central Florida, to Orlando, to spend a day to be with us and to educate us. So I'm so very grateful to them. I'm also very grateful to the vendors for their support. No educational conference is going to happen without their support, and I'm so very grateful to all of them for supporting us to make this event successful. And with this, we will get started with our program, and this is finally the time and state. So we always have a goal post on what we want to do, and this year we have established ourselves as one of the top EUS units and endoscopy programs. We have concluded 4 randomized trials and published about 45 manuscripts. We wanted 30 in our third year, but we are a little ahead of the goal, and all that we have is a transplant program to be set up in the coming years. But most importantly, thanks for being here, and we will get the conference started, and I'm so very grateful for your presence. Thank you.
Well, good morning. My name is Rob Hawes, and it's a pleasure for me to be part of this meeting and also to chair this first session. We have this divided into different subject areas, and the first one will be esophageal diseases. I think that, as Shyam mentioned, I think one of the great pleasures that we have is to be able to host these meetings and invite experts to come and be a part of it. And I've got, I think, the best leadoff hitter in esophageal diseases in the world in Pete Kahrilas. Pete has attended most of these, maybe not, maybe all of them. And he's had an enormous impact on esophageal diseases. And one of his signature sort of creations, if you will, is the concept of the Chicago classification. And we've asked him to present the latest version of the Chicago classification and then to tell us what the impact is on our clinical practice. So Pete, welcome, my friend.
Thanks, Rob, and good morning, everyone. Yeah, so Rob tasked me to present what's new in version 4 here. Well, let's start out with version 3. And this was vintage 2015, and the big advent of high-resolution manometry really was in clarifying achalasia. And that remains the case even in version 4. But we had this hierarchical approach and divided everything into major, minor motor disorders, much the way conventional manometry had been defined. But as we contemplated this, we thought there were some things that could be improved. There was no standard protocol for doing manometric studies. There's always a tweak for achalasia. Big bugaboo was EGJ outflow obstruction, kind of a new entity in the Chicago classification, and it caused us some great problems. Spasm is something I'm not sure really exists. There was this issue of hypercontractility. IEM, this is like quicksand. Everybody always gets stuck in IEM, worrying about where you draw the line. And then, for all of its complexity, manometry was not saying anything about the barrier function of the esophageal gastric junction with respect to reflux disease. So subgroups were formed, and this has become a huge international consensus at this point. There are like 50 participants from 30 some odd countries, and we put together subgroups to look at each of these. So as far as the protocol, this was the publication that emanated from that, and this is what they decided. You don't have to do everything on everybody. Here's your basic. You do 10 water swallows, but it doesn't end there. And I think that was the thing. Everybody said, well, you can't make us do this, that, the other thing. But there are circumstances where you need to. And if you don't get your answer there, well, you change the position, because sometimes position really matters. Sometimes you give a rapid drink challenge if you have a high index of suspicion and you're not getting your answer with 10 simple swallows. And then if you still don't see anything, try solid food. There are circumstances where that's going to give you an answer, especially if you're suspecting rumination. There's a protocol. Do a postprandial study. And if that's equivocal and you're still not getting your answer, do another test. Because a key element here is that there is no gold standard. You don't diagnose motility disorders by a blood test or a biopsy. You diagnose them by function. And if you don't see the functional abnormality with one test, do a time barium esophagram, do a flip study. And then the report should have certain elements to it. You should, of course, define the metrics that have been so carefully devised, the IRP, the DCI, the latency interval. But also, we have these two new ones here, the separation between the lower sphincter and the crural diaphragm, and this EGJ contractility index. Those are metrics of the competency of the EG junction. And then symptoms. This was something that was completely ignored in the earlier versions here, and it's just going around again. We went the same way with conventional manometry. You have to have relevant symptoms. So how did this play out? Well, with achalasia, it didn't make much difference. And like I say, this was one of the things that was incredibly improved upon with high-resolution manometry. Yeah, there's some little tweaks here. You can supine and upright or upright, whatever, but you have to demonstrate both absence of peristalsis and outflow obstruction. And if you don't see it in one position, you do it in the other position, you do it with a rapid drink challenge, because there is no absolute threshold here. It's a matter of function. And what's a relevant outflow obstruction depends on how much push you have. And obviously, if you have a very flaccid esophagus, it doesn't take much obstruction. EGJ outflow obstruction, this was a big one. And this was the subgroup that was tasked to do that, led by Arian Breedenord. What were the problems? Well, in version 3, all it took was an elevated IRP and preserved peristalsis. And in different hands, the prevalence of this varied widely, between 5 and 24%. Dysphagia was the dominant symptom, and true, as we identified initially, this could be incomplete or evolving achalasia. You don't wake up one day with achalasia. There is an intermediate point between normal and full-blown achalasia, and that might be what you're seeing. But this is the sad part of that. Anywhere from a third to almost all did not require any therapy and resolved spontaneously without intervention. And here what you're seeing is the variability in the way people do manometry. There was very poor inter-rater diagnostic agreement. And you see, another thing that comes up is, of course, we're using the best equipment. We're using carefully calibrated things, but you throw this out in the real world, and that's not necessarily the case. So there were problems. And this was the biggest problem, that many patients diagnosed with EGJ outflow obstruction underwent unnecessary aggressive therapeutic interventions, and every publication that you saw advised caution, caution, caution. Why? Well, if you look at the heterogeneity here, yes, the IRP is greater than 15 in 10 water swallows. That can be a matter of compromised deglutitive relaxation, or it can be a consequence of a structural abnormality with mechanical obstruction. So this is where we started. Yes, this can be evolving achalasia, defined as, the 95th percentile of high IRP. But then there's the other 5%. Okay, it just might be high because they're above the 95th percentile. Or this could be a consequence of opioid use, psychological distress, hyperventilation, and you're getting too much of a diaphragm signal in there. Or there are all the structural abnormalities that can give you a high IRP. So this is why caution, caution, caution. So what did they do in version 4? Well, this is the algorithm that was developed. First of all, this is always an inconclusive diagnosis. You have to prove that this is a relevant diagnosis before you act on it. Yes, you can have typical achalasia, but if there's peristalsis, are you seeing an elevated intrabolus pressure? Can you elicit it with a rapid drink challenge? Well, if you can, that's good. If you can't, ignore it, because it's probably not relevant. Is there dysphagia? Do you have relevant symptoms here? Chest pain, dysphagia? Well, if you don't, again, ignore it. If you do, you got to go to a secondary test, a time-barium esophagram or a flip study, or pharmacological provocation, which practically nobody does anymore. And if you have all of those things, yes, then you have a conclusive diagnosis, and then this becomes actionable. If you don't, it is not actionable. How about distal esophageal spasm? Well, this is the working group task to look at that. The defining criteria remain the same. Premature contractions with a high DCI. These little blippy things don't matter. You've got to have something that actually has contractility to it. In version 4, rather than looking at a top to bottom hierarchy, we looked at it in two ways. There's outflow obstruction and there's peristaltic function. So this is a disorder of peristalsis. Again, you got to have a relevant symptom. There were many concerns about technical pitfalls in the diagnosis, and I think the most important concept that comes out here is that this is a rare diagnosis, and most of the time you're within the spectrum of spastic achalasia here. You may not see it right away, but this is usually a manifestation of outflow obstruction plus contractile function of the distal esophagus. A lot of the patterns that were seen were really reflux. Opioids, again, can be confounding, and caution, caution, caution. And I think this was the message top to bottom with version 4 versus version 3 is that don't jump on these things. Remember, there is no tissue diagnosis here. There's no blood test. These are disorders of function. You have to have relevant dysfunction. So this was the diagnostic algorithm that evolved. You have 20% premature contractions. Is there dysphagia, chest pain? Yes, then that's conclusive. No, ignore it. If you don't have those criteria, meaning a high contractility as well as a short latency, it's unlikely that this is really a relevant finding, and it's always going to be inconclusive. If you want to prove it, well, you can do multiple repetitive swallows and show that there is no deglutitive inhibition, no pressurization, but even then it's still inconclusive. Basically, this is a rare diagnosis, and the best you're going to do without those defining characteristics of a good contraction on top is possible DES. How about hypercontractility? This was the working group looking at hypercontractility. There you see it over there. The only difference here really is that they upped it to 2 instead of 1 of these hypercontractile swallows. Again, you got to have relevant symptoms. It's heterogeneous. You can have a variety of patterns. You're seeing a couple of them here. And jackhammer is now just a subtype. It's no longer synonymous with hypercontractility. And again, caution, caution, caution. These people don't need a myotomy done. It has to be a relevant finding before you go that route. So yes, if you have relevant symptoms and you have this abnormality, that's conclusive. If not, ignore it. If you don't have the 2, but you only have the 1, it's probably not relevant, and it's gonna be inconclusive. So look at other investigations here. IEM, again, this is quicksand. You know, you get a group of modalists together and they start talking about IEM and just pour yourself a drink. It goes on forever. And then there's the issue of barrier metrics. Now, this was the subgroup that I actually headed, and it was a very frustrating thing because at the end of the day, we kind of squeaked in with some mention of LES-CD separation, kind of an obvious thing. Is there a hiatal hernia? You know, do you have spatial separation between the diaphragmatic contraction and the lower esophageal sphincter? And there you don't. Here it's transitional, and here you do. But that's about all we could really agree on, because this metric of the EGJ contractile index, EGJ-CI, what you do there is you just put a DCI box around 3 respiratory cycles and see how much contractility is in there. But, you know, people couldn't even agree. Look at the third instance there. Some people say, well, you isolate the lower sphincter from the crural diaphragm. To me, that's not fair, because the other 2 don't. The other 2 are including both. But at the end of the day, you get a group of 50 people from 30 countries, and let me tell you, it's the United Nations. They can't agree on a damn thing. So that was left as undecided over there. But at least we got the LES-CD situation clarified. So what are the major changes here? Well, there's a standard protocol now for doing manometry, and that's a big deal. EGJ outflow obstruction has clearly been clarified. Minor tweaks to these diagnoses. Barrier metrics, well, we introduced these things, and hopefully they will live on. And this is the publication that emanated from that. And I'll point out that Reina is now a professor of medicine at UCSD and a former super fellow, and John is now my chief, mastermind of the Chicago classification and also a super fellow. Thank you. Stay up here.
We're going to keep questions for the time during the case presentations, so we'll wait for that. Next up is Sachin Wani. Again, he needs no introduction. He's a superstar from the University of Colorado, and certainly one of the world's experts in Barrett's esophagus, with many, many other gifts, including teaching and measuring those metrics, et cetera. So it's great to have Sachin back. He's one of our frequent travelers, and we've asked him to talk about surveillance after endoscopic ablation of Barrett's esophagus. So Sachin, welcome, my friend.
Thank you so much. Good morning, everyone. Thank you, Rob, for that kind introduction, and thank you to the course directors for having me back again. This is one of my favorite conferences to attend all year round. So I'm going to spend the next 15 minutes talking to you about how we should be managing patients after we achieve the endpoint of complete eradication of intestinal metaplasia. So I'll start off by answering this fundamental question: how common is post-eradication esophageal neoplasia and post-eradication intestinal metaplasia? When are you most likely to identify a recurrence of intestinal metaplasia or neoplasia? Do we have any information on predictors that are associated with recurrence? And what are the basic principles as it relates to management of these patients if you were to identify a recurrence of Barrett's or Barrett's-related neoplasia? I will spend some time talking to you about the management of these conditions, how you should be performing surveillance as it relates to surveillance intervals, and what your sampling protocol should be for this patient population. I'll also challenge you all to think about how we can potentially provide a personalized approach to these patients once you've achieved the endpoint of complete eradication of intestinal metaplasia, as opposed to using a cookie-cutter approach as it relates to surveillance intervals. I'll do all of this in the context of published guidelines by our GI societies. I'll highlight some of the knowledge gaps that exist and some of the ongoing studies that we're conducting to address some of these knowledge gaps. So let's talk about some of these concepts. These are the guidelines that I will be focusing on. These are the guidelines published by our GI societies. I will be focusing on the two most recent guideline documents that we published, one through the American College of Gastroenterology and the most recent guidelines that really just focus on endoscopic eradication therapy through the AGA. So just a few basic concepts. I think we all in this room recognize that endoscopic eradication therapy is safe, it's effective, and this is a minimally invasive treatment strategy for management of patients with Barrett's-related neoplasia, an approach that is now endorsed by all our GI societies. Let's take a couple of minutes to understand what our goals are when we do perform endoscopic eradication therapy for our patients with Barrett's-related neoplasia. So our first goal, which I think of as our immediate effectiveness goal, is to achieve complete eradication of intestinal metaplasia. That's the finish line. We achieve this by a combination of endoscopic mucosal resection for any visible lesions, followed by radiofrequency ablation until we achieve this endpoint. Relevant to this talk is how you define complete eradication of intestinal metaplasia. Now, there's some varying literature as to the definition of this endpoint, but by and large, if you have 1 or 2 endoscopies that demonstrate the absence of intestinal metaplasia or neoplasia from biopsies obtained from the neosquamous epithelium and the gastroesophageal junction, you've achieved the endpoint of CEIM. Our next goal, again relevant to this talk, is our intermediate goal of reducing future neoplastic recurrences and management of these recurrences if you do encounter these in your practice. And our long-term goal, of course, has to be reduction in esophageal adenocarcinoma mortality, and unfortunately, we have the least amount of data for this specific endpoint. Now let's try and answer this question about how common are recurrences in our clinical practice. This table highlights all the contemporary studies, including systematic reviews and meta-analyses that have tried to answer this question. If you look at the endpoint of recurrence of intestinal metaplasia, this really ranges from about 5 to 10 per 100 patient years. If you focus on the endpoint of recurrence of dysplasia, the incidence ranges from about 1 to 3 per 100 patient years. If you really just focus on the endpoint of high-grade dysplasia or cancer, this can be up to 1.6 per 100 patient years. Now let's spend a few minutes really diving deep into at least 2 of these contemporary studies, one here from the United States and one from the Dutch group. I'm going to focus on one of the largest cohorts that has been reported, at least here in the United States. This is from the TREAT BE consortium. This was funded by the AGA, and we really embarked on this project to understand clinical outcomes related to endoscopic eradication therapies and to set quality indicators in EET. What our study showed, and this included more than 800 patients that had achieved complete eradication of intestinal metaplasia, we showed that the recurrence of intestinal metaplasia was 15% for an incidence rate of 5.2 per 100 patient years. For the endpoint of dysplasia, our recurrence is very similar to what's been reported by the Dutch group, which is about 1.6 per 100 patient years. This is the Dutch study that I was referring to. This included about 1,400 patients that underwent endoscopic eradication therapy. They looked at the durability outcome in more than 1,100 patients, and what they showed us was that the annual risk of recurrence of any neoplasia, which uses a composite endpoint of high-grade dysplasia, low-grade dysplasia, and cancer, was 1%. So the annual risk is fairly low. It's about 1%. If you look at the endpoint of high-grade dysplasia and cancer, the annual risk is even lower. It's about 0.7%. Only 5 patients in this entire cohort progressed to advanced esophageal adenocarcinoma. So we're doing a really good job in managing these patients with Barrett's-related neoplasia. There are a few other important key takeaways from these studies that have been published. I will tell you that the vast majority of recurrences that you will encounter in your practice will have some endoscopic abnormality. So really gets down to the importance of performing a high-quality endoscopic examination in this patient population. I will tell you overall, even though this is a part of our practice, the yield of taking biopsies from the neosquamous epithelium is fairly low. You will frequently encounter intestinal metaplasia from biopsies that you take from the gastric cardia. I will tell you that in about 33% of the times you will be able to confirm that diagnosis on a subsequent endoscopy. The remaining patients, you're not going to find IM again. There's also data suggesting that IM in the gastric cardia really has no correlation with any recurrence of Barrett's-related high-grade dysplasia or cancer. And these data have also shown that frequent follow-up in the first year is not associated with any clinically relevant recurrence. The good news is that the vast majority of recurrences that you're going to see in your practice will have the same histology or a lower grade of dysplasia when compared to the histology that you started off with when you embarked on endoscopic eradication therapy. In terms of timing of recurrence, these are again data from our cohort confirmed by 2 other large cohorts of patients undergoing treatment. Using the kernel density estimate, we showed that the vast majority of recurrences actually are identified at 18 months after you achieve complete eradication of intestinal metaplasia. So what are some of the predictors that you could potentially use in your clinical practice so that you can identify those patients who are at the highest risk of having a recurrence? Again, I will submit to you there are limited data answering this important question. From our cohort, we identified the following predictors. Your baseline grade of histology or dysplasia is probably one of the strongest risk factor for recurrence. It's no surprise that patients with high-grade dysplasia or mucosal cancer undergoing endoscopic eradication therapy are patients who are at the highest risk for having a recurrence compared to those patients with low-grade dysplasia. Uncontrolled reflux disease, large hiatal hernia, and the number of sessions that it takes you to achieve the endpoint of complete eradication of intestinal metaplasia is also an important predictor for recurrence of Barrett's-related neoplasia. When you think about where are you going to find recurrence of IM or neoplasia in patients undergoing surveillance endoscopy, the message is very clear. The vast majority of recurrences are in that distal 2 centimeters of the esophagus and the gastroesophageal junction. Of course, you should be examining the entire esophagus, but if you have to focus most in an area where recurrences are common, it's in the distal portion of the esophagus and gastroesophageal junction. I want to take this moment to really highlight some of the key elements for a high-quality endoscopic examination. And I want to use this example of a patient that was referred to us with a recurrence of Barrett's with high-grade dysplasia. This patient underwent radiofrequency ablation at an outside facility and then was referred to our practice. Unfortunately, the video is not playing. Would you mind playing this video? I know it played earlier, but I'll just go over some of the key concepts. I think the same concepts that you use for performing screening and surveillance are applicable for doing endoscopy for patients who are undergoing surveillance after complete eradication of intestinal metaplasia. It's really important for you to use a distal attachment cap. I think it really allows us to identify the mucosal and the vascular abnormalities that we identify in patients with Barrett's-related recurrence. It's important to use a combination of high-definition white light endoscopy and virtual chromoendoscopy. Virtual chromoendoscopy not only will help you identify the recurrence, but it'll also help you to predict what the histology is. We use virtual chromoendoscopy to actually mark the area and help us guide our endoscopic eradication therapy. So again, it's really important to spend adequate time inspecting the Barrett segment, and of course you should be using the Paris classification if you find any visible lesion within the esophagus. Now, this flow chart really just summarizes how you should be managing patients once you've achieved complete eradication. And the box on the left, again, focuses on the basic tenets of a high-quality endoscopic examination. Sampling should include the distal 2 centimeters and the gastroesophageal junction. And when you bring this patient back is really dependent on the baseline histology. For patients with low-grade dysplasia who've achieved complete eradication, bring them back at 1 and 3 years after complete eradication of intestinal metaplasia. Those patients with high-grade dysplasia and mucosal cancer, bring them back at 3 months, 6 months, 12 months, and then on an annual basis. basis. It's really important that we all commit to the quality indicators that have been established for endoscopic eradication therapy, and I'll share a slide on that towards the end of my presentation. But what's really important is the column to the right. These are some of the knowledge gaps. We're almost 2 decades into doing endoscopic eradication therapy, and it's shocking to me how we've not addressed some of the key issues in the management of this patient population. So the first question that I want to ask the group is, can we potentially use non-endoscopic strategies to actually do surveillance as opposed to doing endoscopy? That really needs to be looked into the future. Ongoing studies as well. Can we use advanced imaging modalities to identify recurrence? There's no doubt in my mind that artificial intelligence platforms will bring about the greatest disruptive change in our clinical practice. Can we use AI platforms to actually identify recurrence of Barrett's-related neoplasia? Can we use advanced sampling techniques to better detect recurrence? We do have an ongoing randomized control trial that's looking at wide area transepithelial sampling to see if that can improve our detection of Barrett's-related neoplasia. And this is something that I feel very strongly about. We really need to have a personalized approach as it relates to management of these patients that must use a combination of clinical, demographic, endoscopic, and pathologic variables to identify those patients who are at the highest risk for recurrence. Maybe throw in biomarkers to identify those patients at risk as well. And then finally, the question we have is, can anti-reflux surgery or endoscopic procedures reduce the incidence of recurrence? These are some of the ongoing studies that have looked at these models. These are data from the Dutch group. They've developed a model to look at factors that are associated with recurrence, and based on this model, they can do a fairly good job in identifying those patients at risk. Look at the predictors that they've identified, very similar to those that have been reported by the TREAT-PE consortium, and they recently externally validated their model as well. We've taken it a step further. Not only have we created a model to identify those patients who are at risk, but imagine a time if you could plug in all the numbers and data related to recurrence, and it actually provides information on not only your risk of recurrence, but also gives you a heat map to guide when these patients should come back for their surveillance endoscopy. I'll put in a plug for the ongoing SERVANT trial, which will answer some of the questions as it relates to surveillance for this patient population. This is an ongoing study that's funded by the NIDDK. It's looking at patients with low-grade dysplasia and randomizing these patients to surveillance or ablation. We're focusing on neoplastic progression, but we're also looking at biomarkers that allow us to identify those patients who are at risk for progression and identify those patients who are at risk for recurrence. My immense gratitude to the 26 centers that are participating in this study. If you have a patient with low-grade dysplasia, please consider referring your patient to one of these participating trials. The SERVANT trial provided jet fuel for this next study that we are conducting, which really looks at aneuploidy and biomarkers that are associated with recurrence for patients who've achieved complete eradication for intestinal metaplasia. This is the flowchart that we've presented in our most recent guideline document. I encourage you to take a look at this at your convenience and recognize that we have quality indicators that have been established for endoscopic eradication therapy. And our guidelines now recommend that if endoscopic eradication therapy is a part of your practice, you are required to monitor your key outcomes and performance as it relates to the benchmarks that we've established for managing these patients, which include how often are you achieving complete eradication of intestinal metaplasia, and what are your adverse event rates for this patient population. So in conclusion, recurrence rates after endoscopic eradication therapy, at least at expert centers, is low. Enrollment in endoscopic surveillance programs is recommended given the fact that you can see recurrence of intestinal metaplasia and neoplasia. One of the key interventions to reduce and detect recurrences is to perform a high-quality endoscopic examination. How often you bring them back is really based on their baseline histology, and I encourage you all to commit to the quality indicators that have been established for endoscopic eradication therapy. Thank you so much for your attention.
Thank you very much, Sachin. So I'm going to ask Pete Kahrilas to come back up and talk to us about the management of heartburn, in quotes, when PPIs don't work. This is an area that Pete has, at least in discussions with him, has shown some great wisdom. So I'm anxious to hear what you have to say.
Yes, I'm going to be wise. So, you know, the initial management of, I just say, reflux-like symptoms is fairly straightforward. You treat it as though it's reflux disease, and we know this hierarchy. If there are alarm features, you get endoscopy. If it works, that's great. If it doesn't work, you get endoscopy. Even if it does work, you end up getting endoscopy. So you get endoscopy. But this is kind of the problem here, that if you look at well-defined reflux disease here, meaning endoscopy or pH-metry positive, a lot of them are going to respond to PPIs, and that's great. Those are the PPI non-responders, though. And then if you look at the other group here that are negative with respect to objective criteria, it's 50-50. So PPI response does not define reflux disease. I mean, there's a fundamental difference here. It's pragmatic, but it's resulted in an awful lot of PPI use. And indicative of that, 25% of adults are prescribed a PPI at some time. That's a lot of people. And a lot of people are taking them for a long time. Most commonly omeprazole. And this is the way it goes. You know, this is if PPIs don't work, what do? Well, check the timing, split the dose, increase the dose, switch the PPI, throw in a PCAB, maybe anti-reflux surgery. Well, do you investigate them up there, or do you investigate them down here? And I think the answer is increasingly here, at the bottom. You don't go up that ladder all the time, and this is why. If you're talking about healing esophagitis, yes, you accelerate therapy and it works. There's a huge therapeutic gain there, the green arrow relative to the blue arrow, an NNT of less than 2. But when you talk about heartburn relief, look at how you're shrinking here. This is with or without esophagitis. This is without esophagitis. Now you're under 40%. And your NNT is much different. And if it's regurgitation you're treating, it's even a narrower therapeutic gain. So the problem with this latter approach of just increasing anti-secretory therapy is it's led to overuse of PPIs, and that's led to a lot of scrutiny of adverse events, and I think we're all familiar with that. It's led to a lot of misguided surgical treatment, too much surgery for the wrong patient and not enough surgery for the right patient. But this is the fundamental problem. It assumes that reflux-like symptoms share the same pathophysiology as reflux esophagitis and the same dose-response characteristics. But the only manifestation of reflux disease with a clear dose response to acid inhibition is reflux esophagitis. It ignores the gut-brain interaction piece. So let's talk a little bit about endoscopy. What are you going to find out? Well, first of all, people now say, stop the PPI before you do the endoscopy, okay? And you might find esophagitis. And if you do, then yes, escalate anti-secretory therapy. Are all PPIs alike? No. This is looking at their ability to keep the intragastric pH above 4. And there are big discrepancies here. I mean, pantoprazole is very weak compared to rabiprazole. And vonoprazan, look at that, the black line up there, you can practically stop acid secretion with it. And sometimes that's going to matter. PPIs you can do twice a day, and then they're pretty much approximating what vonoprazan can do, but that's not an FDA-approved dose. What else might you see? Well, you might see eosinophilic esophagitis, and then you kind of go down this other pathway there of budesonide or dupilumab. But this is a very interesting story because the distinction between EOE and reflux disease is a continuing paradigm shift. In 1982, eosinophils were diagnostic of reflux disease. Then Atwood came along and said, no, EOE is distinct from reflux disease. It has something to do with allergies. And then in 2007, response to PPI therapy is a diagnostic tool that rules in reflux disease and rules out EOE. Interesting. Then in 2011, response to PPI therapy is a diagnostic tool that rules in a new entity, PPI responsive esophageal eosinophilia, and rules out EOE. Then in 2017, no, that's not really a diagnosis. PPI therapy is a treatment for EOE, and response neither confirms reflux disease nor precludes EOE. And now I think we're back to 1982 here, that esophageal eosinophilia includes EREFs, including EREFs, can be a manifestation of reflux disease, and it responds to PPIs. So, yes, there is an entity of EOE, but just finding eosinophils on biopsies is not a diagnosis of EOE. It's usually reflux disease. Barrett's, we just heard about Barrett's. You can find that, and it has its own management paradigms. But this is what Rob really wanted me to talk about here, is normal esophageal mucosa, or LAA esophagitis, which is increasingly recognized as normal. What do you do there when they have heartburn? Well, Rome 4. So Rome 4 says you got to test them, and this is what you're going to find out. You're going to see either abnormal acid exposure or reflux symptom correlation on a prolonged pH metry study. If there's erosive esophagitis, supposedly it's abnormal acid exposure and symptom correlation. If you have true NERD, abnormal acid exposure and positive symptom correlation, just like esophagitis. But then there's reflux hypersensitivity, where they just sense it a little better, so it correlates, but it's not abnormal. And then there's functional heartburn, where everything's negative. Well, getting back to that Diamond study here, is this really true? I mean, they came up with this, but is this really true? Well, this is this group who had all the studies done, and these are the ones who had either esophagitis or abnormal pH metry. And look at it, the 20% wedge there are the ones who are behaving the way Rome said they're supposed to behave. The rest of them didn't behave that way. So this is a construct that really was made up and never tested. The only test was really that Diamond study, and a Diamond study said that's not true. So the major problems with the concept of PPI refractory reflux disease is that we've created a monster here. That by defining reflux disease as a condition which develops when reflux of stomach contents causes troublesome symptoms and/or complications, it erroneously assumes that symptoms and esophagitis share a common pathophysiology, and that ignores the gut-brain axis. An extraesophageal reflux disease is usually multifactorial. Reflux is usually a minor player. It really shouldn't even be called reflux disease. And Rome 4, by invoking this testing and then divvying it up to functional heartburn and all that, requires using pH metry and reflux symptom correlation to make these distinctions, but these are unreliable and often unavailable. What about symptoms? Well, most PPI refractory reflux disease, or PPI refractory heartburn, is defined by a refractory symptom. And while esophageal symptoms can be related to abnormal physiology, there's a big disconnect between symptom severity and the degree of physiological abnormality. You're ignoring psychological stressors and cognitive behavioral factors, and the fact that the central nervous system is plastic. You have this hypersensitivity, and things change. And then there are people's reaction, hypervigilance. And that probably explains a lot. And that's where this concept of the esophageal hypervigilance and anxiety scale comes up. And what is this? Well, this is something that developed by the Northwestern psychologists, and it developed a 15-item questionnaire, and this is the type of thing that go in there. And all of these things get rated on a 0 to 4 scale. I can't seem to keep my symptoms all out of my mind. These symptoms are awful. There's nothing I can do. So those all came from the Sullivan pain catastrophizing scale. And then there's the visceral sensitivity index here. I often worry about problems in my throat. And every one of these things gets rated. Or here, I'm quick to notice changes in the location or extent of my esophageal symptoms. I think you get the drift here. As soon as I wake up, I worry about it. Yeah, me too. And all of these things get rated 0 to 4. So there's an anxiety component and a hypervigilance component. You can end up with a score of 0 to 60. So how does this play out? Well, this is the Rome groups, okay, so these people had the testing done and they're subdivided into NERD, hypersensitivity, functional heartburn. Their acid exposure time is, of course, different because in NERD it's abnormal, in the others it's normal. In terms of number of reflux events, same thing. It's abnormal with the true NERD. Mean nocturnal baseline impedance, same thing. How about symptoms? Well, the symptoms are the same. There's no difference with the true NERDs from the reflux hypersensitivity or the functional heartburn. They all have the same GERD-Q score. And they all have the same EHAS score. So the only thing that correlates with symptom severity is the EHAS score. There's absolutely no difference between reflux hypersensitivity and functional heartburn here. And this is the kicker. This is a brilliant study done by another one of our psychologists who now looked at almost 500 people who were refractory to twice-daily PPI, and they did the testing, okay? So they were able to subdivide them into these Rome 4 categories, but they also did 13 questionnaires on psychosocial functioning, and then divvied them up here. They classified them by the Lyon 2 consensus into the true GERDs, the borderlines, the reflux hypersensitivity, and the functional heartburn. And they used a machine learning approach applying multiple potential models to ascertain the best predictors of their perceived reflux symptoms, severity, sleep disturbance, whatever. I'm going to focus just on the reflux severity here. Look at how well that machine model did. First of all, they put the conventional statistical approaches to shame. That's the right panel. On the left panel, they were able to create a model, the gradient boosting tuned number 2 model, that had an R-squared value of 0.87 and an R value of 0.94 in predicting symptom severity. That means you're accounting for 87% of the variance by that model. And what went into that model? Variables 1 through 12 were all psychological variables: GI-specific anxiety, illness behavior, body awareness, pain anxiety. The combined worth of these things in that model, if you weighted them, was 0.7 plus. Then these are the physiological variables: number of reflux events, the Lyon classification, total reflux exposure. The combined worth of all of these things was 1/7 of that. So this is the model that is evolving here, that the pathogenesis here is this combination of altered physiology and altered perception. And as you migrate from erosive esophagitis to these other entities, you get away from the physiology and the things which we learn about over and over again: obesity, older age, hernia, diet, alcohol, smoking, and you get into these factors over here, which is the non-PPI side of it. These are the hypersensitivity, hypervigilance, anxiety. This is what drives symptom perception. And how do we treat them? Well, yes, we like to use drugs, so antidepressants in low doses are effective. This is not an FDA-approved indication here, but yes, that is the way we approach it. So what do you do at the end of the day, Rob? Well, you use these tests, which we know and love, to look for alternative diagnosis with alternative treatments. Sometimes you need to escalate PPI therapy, but it's usually not the answer. There's the eosinophilic esophagitis problem, there are the motor disorders. Regurgitation is a different deal entirely because that implies you have mechanical dysfunction. Then you have the belches, the ruminators, But residual symptoms stem from some combination of reflux, hypersensitivity, hypervigilance, anxiety, psychiatric comorbidities, and misdiagnosis. Consider the gut-brain interactions early, not as a last resort. Yes, use TCAs, SSRIs, but most importantly, PPI refractory GERD or PPI refractory heartburn is not a diagnosis. Thank you.
Always brilliant. Thank you, Pete. So it's next my great honor and pleasure to introduce Dave Johnson. He is one of our emeritus faculty members. Dave is what I call my utility infielder. If I need an exceptional talk on any subject in GI, then I call Dave. But most recently, Dave has sort of carved out a real niche. He's become an expert in the gut biome, which we know is one of the most important upcoming things. And so we've asked him to actually talk about the gut biome as it relates to the esophagus. And should we discard Pete and his acid theory and go to Dave Johnson with his bacteria theory? So I'll let you all decide that. Dave, welcome.
Can I vote now?
Yes.
Well, good morning, and thank you. I've added a bit on this that I really want to expand on the esophageal and the oral microbiome. I think I call that the low-hanging fruit. We've certainly missed a lot of opportunities as we start to look at this going forward. So let's talk about really where we are today. And the compliments are to the directors, because if anybody's been watching the national news for the last 2 weeks, it's been horrific. If you start to look to the Northeast, pictures that I've snapped from the recent photos from the Northeast in the last week alone, you start to look at these things. How many people have shoveled their roof before? Come on. And look outside, and Rob and Shyam have been frenetic trying to communicate with some of our northern faculty, and up to the last minutes locating these people has been quite difficult, but thank heavens for cell phone, and they've, I think, all arrived, so I think our faculty is uniformly here, and you're in for a real treat the rest of the week. So as it relates to the course directors, thank you, because it's 75 and sunny, so thank you, thank you, thank you. It could have been in the Northeast. My goals today are really multifocal. In particular, I want to begin on the oral biome because it's something that we have not considered. I have not considered it until more recently. And the dysbiosis is not just about dental disease. We're going to talk about it. It's not just about cavities, but it's local effects and systemic upregulation of cytokine inflammatory translocations. And we take caries to cancer. And in particular, I'll expand on that, how that's potentially very applicable to what we do in our general GI approach. Esophageal microbiome we'll talk a bit about as well, and looking at new factors as it relates to dysbiosis. And it's not all acid. It may be taking A, acid, to B, bacteria. And again, the interrelationship, I'll expand on that going forward. And I'll leave you with interactions of what I've seen in doing this now for a number of years, and I like to look at this as direction and wisdom. There's a lot of noise out there. What makes sense? And I'm going to do a drill down on really what makes sense and why I think we should all consider these things going forward. Let's start with the oropharynx. And the human oral cavity is colonized by over 1,000 bacterial species, ranging from Streptococcus here to Fusobacter. But there's clear evidence, if you think about what goes on in the biome in the oropharynx, that this has local disease. We see dental caries, we see gingivitis, periodontal disease, oral cancers, all related to what goes on in the oropharynx. But there's increasing evidence, however, for systemic disease effects, and I really want to have that as a take-home point for you today. This is a highly complex mucosal interface. When you start to look at it, there are varied environmental niches. You talk about the tongue, the oropharynx, the gingiva, above and below the dental surface as it relates to the gingiva. And again, these are micro pockets as it talks to environment, each and every one of them housing its own microbial community. As such, you have the constant antigenic exposure for what we do and what we introduce to our mouth. With that, you have the protection. White cells are present to guide and protect us, and there are pro-inflammatory cytokines to respond and protect us from these potential pathogens, in particular interleukins 1 and 6 and TNF-alpha. Those are discriminants. We start to talk about other diseases, and it can be very foreboding, and the approach to that in other diseases we'll talk about. But the critical role of the oral cavity and immune surveillance has really only been recently appreciated. So let's drill down on that and talk about this a little further. Local and systemic effects of the oral gut, and in fact, it's the second largest microbial community after the GI gut, and it harbors more than 700 species and over 1,300 bacterial strains. It's a very diverse array, and it ranges from bacteria to amoeba to flagellates to archaea and viruses. So we're going to talk particularly about bacteria today, but recognize that there's a diverse array that's a broad spectrum. Alterations in oropharyngeal biome have significant potential implications, translocation of those microbiomes or the metabolites of those biomes, and systemic effects relevant to GI and non-GI diseases. And we'll talk about that. Bridging as you start to look from local effects here and think about the upregulation of cytokine responses and things that adhesion-like cell processes, toll-like receptor pathways, induction of reactive oxygen species, or generations of mutation-initiating DNA changes. And again, these are things that have mitotic implications as we start to think about cancers and dysplasia. Let's start with first dental health in the US. This is a very recent survey, selected findings. Nearly 21% of people there 20 to 64 years have one or more of their permanent teeth with untreated decay. Now, if we take that a further step and talk about tooth retention and edentulation, more than 1 in 10 adults aged 65 to 74, raise your hand if you're in that group, but I'll take my hand down, have lost all their teeth. These are dental statistics. I'm not making these up. And if you get to 75, the number goes up to 1 in 5 that have lost all their teeth. We got that to look forward to as we go older, right? But nonetheless, there's a lot of things that we don't really comprehend how prevalent they are. Now let's focus on GI diseases. I'm going to talk a bit about IBD, colorectal, Barrett's, and squamous cell cancers in a minute, but let me just make 1 or 2 comments about the fatty liver disease, and as well, and then we'll talk about hepatocellular carcinoma and pancreatic ductal carcinoma. A couple words just about hepatocellular. There's clearly a biomic footprint that is associated with this, particularly with Fusobacter and Oribacterium. These are things that have been associated, but these are associated with advanced periodontal disease as well. As it relates to pancreatic ductal adenocarcinoma, the carriage of Porphyromonas gingivalis, P. gingivalis, is associated with, again, periodontal disease, but it's highly associated with increased pancreatic ductal cancer risk and mortality. Administration orally in mice accelerates the progression of pancreatic cancer in mice, and the prevalence of this in an oral microbiome is found in the gut, the pancreas, and also the tumor itself as it relates to P. gingivalis. So again, highly associated with this disease. How about inflammatory bowel disease? Well, this really makes sense. Pathobionts from the oral cavity cause periodontitis. We know that. But especially certain bacteria, Enterobacteriaceae, in particular Klebsiella and Enterobacter, also have a systemic cytokine upregulation. Remember we said TNF-alpha, IL-6, IL-1. These are things that we have pathogenic implications and pathways as it relates to inflammatory bowel disease. So after penetration into the gut, these active phagocytes, remember the gut, you have white cells in your mouth, they penetrate the gut and they cause colonic inflammation. They migrate to the colon, and very interesting, these implications of the white cells, these are CD4 positive helper cells, Th1 and Th17, they're actually is a significant part of the immune system. They are responsible for gamma interferon. protection in the oral cavity. But now these bacteria have intestinal tropism. They migrate to the inflamed intestine, and they're activated, very interesting to understand, activated by pathogens only originating in the oral cavity. They're not activated by microbiome that are colonized in the intestine. So again, this starts to really make sense in the IBD world. Now, microbial disease was investigated, at least from an expert in this field, as Ali Keshvarian and his group in Chicago, just at DDW. They showed microbial differences in active versus inactive or healthy control, and they found the microbial differences were inordinately favoring at least a distortion towards the active inflammatory bowel disease and discriminate about both these populations. And in addition, they found a high concordance of periodontal disease as it relates to their population. If we look about cancer, it also makes sense because translocation to the site and incorporation of the tissue has very, very strong associations. And there are mechanistic roles why this makes sense, from caries to cancer. If we talk about Actinomyces odinolyticus, this drives colorectal cancer, a mouth-type bacteria, but it drives it mechanistically by secretion of vesicles, changing microbial dysfunction, mitochondrial dysfunction, reactive oxygen dysfunction, again, driving DNA damage. So again, the oropharynx to the gut, initiating a cancer pathway. Fusobacter nucleatum is also one that's highly concordant with periodontal disease, but now very recently also concordant as it relates to cancer. It's very rarely found in GI health in the lower GI system. It promotes signaling changes, and it has a high intratumoral association with colorectal cancer, as well as recurrences and poor prognosis. So this is something that we have to look at in a way of how these interact and potentially can now drive caries to cancer. This is a fascinating study. This is just published. This is from the Fred Hutch group in Seattle, working in concert with a group in Korea and also the Dana-Farber in Boston. But they recognize, I just mentioned that Fusobacter nucleatum, it individually as a species has two clades, they call clades, so subspecies within that species. And they found that the subclade 2 was something that really mattered as it relates to colon cancer. So these two clades separating this FNAC2 was a dominant role in cancer. Now, how did they investigate that? Well, they took mice, they gave them streptomycin to cause intestinal dysbiosis, and then they gave them dextran sodium sulfate to induce colitis. And then they took their single lavage that they gave to these mice, and then they took the two arms, that the control and the FN1 that was not associated with colon cancer, and the FN2, they gave the same gavage. And interestingly, when they looked at number of adenomas, there was a high concordance with the people that were the mice that got the FN2, the one that caused colon cancer, and the same as it relates to progression to cancer in these mice when they followed them out even further. And they looked at the metabolic dysfunction, and this is really the least squares synopsis of this, but you can see that the metabolic shift as it relates here, or as at least partial squared intestinal metabolites, are highly shifted towards the far right, which is the FN2. So again, cavities to cancer. And this is going back to some seminal work from Julian Abrams and his group in Columbia, at Columbia in New York, a number of years ago, looking at the esophageal biome and seeing distinct markers as it relates to Barrett's versus non-Barrett's, and something that you can look here in the cladogram showing that there are distinct pedigrees that they see in this population. Most recent publication that just came out a couple weeks ago, and Julian shared this with me, is looking at the salivary microbiome. And here we're going to focus on their cohorts that looked across Barrett's, non-Barrett's, non-dysplastic, high-grade dysplasia, and adenocarcinoma. And you can see here on the left, there is a neoplastic progression, highly statistically significant. So the diversity was changing. Lower diversity is more subject risk. And as you looked at the metabolic profile, and this in the beta diversity, there was the same profile, highly shifted in favor. And what they saw in this modeling that they conjured up as well, the micrometabolic capacities in high-grade dysplasia and adenocarcinoma had notable increases in L-lactic acid and decreases in butyric acid, metabolized by short-chain fatty acids, and L-tryptophan. So again, we're seeing biologic differences as it relates to Barrett's. Let's shift now to the oral biome and liver disease. Again, it really makes great sense. The oral has a direct association with the gut, and the gut has association with the liver. And there are recognizable bacteria, P. gingivalis we've already talked about, and Acinetobacter actinomyces comitans, say that 3 times fast. These are, again, oral bacteria, but they're highly associated with liver disease as it relates to also periodontal diseases. And liver disease and inflammation and fat and fibrosis are the culprits as it relates to this dysbiosis. Interesting study where they looked at the radio-labeled, again, P. gingivalis oral bacteria and injected it into gingival areas in mice and then in rats, and they were then fed a high-fat diet, and they showed accelerated hepatic fibrosis. So again, gut bacteria here beginning in the oropharynx, accelerating hepatic fibrosis. And again, this P. gingivalis has many virulence factors, which we've cited already, and signaling events here certainly were upregulated in the liver as well. As it relates to liver and gut, this oral gut-liver axis is something that we're really, again, coming back to the microbiome, originating in the oral area. We talked about IL-1 and 6 and TNF-alpha. But this P. gingivalis that we talked about now for cavities to cancer has also been shown up injecting it, again, in systematic ways and looking at it. You can identify it in the brain, liver, kidney, and throughout the GI tract. So again, contributing by translocation for sure. And we do know that periodontal disease is very prevalent in the inflammatory liver disease, 25 versus 70%. And rabbits that were injected, again, with this P. gingivalis showed accelerated fibrosis, in particular in the liver. This is a very provocative study a number of years ago by Josh Bajaj from VCU. But what they were looking at here was the effect of dental hygiene on patients with minimal hepatic encephalopathy. And they looked here at the endotoxin changes and the cytokine expression with interleukin. And they showed that these decreased in response to referral to a dental clinic. Again, they looked at ways that they looked at minimal encephalopathy. So the scores here, higher is better, so they had better improvement in the score for encephalopathy. And this score that was lower was better. Again, they improved here. And again, lower was better here. The point was they were taking liver patients and sending them to the dentist and had dramatic changes. Now, how small things make a difference comes from a very provocative study from South Korea, and a cross-sectional study of over 6,000 adults. And they looked at the inverse association between toothbrushing and metabolic fatty liver prevalence. And again, the fatty index they used here was a validated instrument, looks at a variety of factors integrated here to create this index. And the modified odds ratio was a risk reduction of over 40% if you had these as far as brushing your teeth 3 times or more a day as opposed to once or less a day. So looking at the oropharynx, I look at this picture and think of what does Mick Jagger's dentist look like? What does he see when Mick comes in for his checkups? 1 or 2 more comments just about the esophageal microbiome. And again, the esophagus is incredibly complex. We look at the species here, basically 6 phyla across the esophageal microbiome. There's a type 1, which is normal esophagus, and type 2 is the ones that migrate more to the gram-negative exposures, and these are things that we start to see with mitigation for diseases in the esophagus. And in GERD, what we see is a shift from type 1 to type 2. Let's look at this, how this works. So the classic acid, if as Peter described, you take acid, you get the pain because it migrates through the esophageal wall. But in contradistinction, acid may have interaction with the microbiome in the esophagus, and this gram-positive, gram-negative ratio, primarily through TLR pathways, now starts to induce on the submucosal level cytokine response. This is what drives lymphocytic upregulation back to the mucosa to change intracellular spaces or actually erosive changes. And again, it's the basement, not the roof, where this acid is starting to migrate from. And it's a cytokine expression and a cascade, again, of these things that we see developing through the oral barrier as well, but how these migrate up and cause damage. Cytokine pathways retrograde moving out to the mucosal side. So GERD injury really comes back to a very provocative seminal work from Rhonda Souza and Stu Speckler that was the notion of acid causing injury at the top, the mucosal interface. Direct chemical injury is no longer really the way that we believe this really works. And in fact, histologically, you can see that this begins begins at the submucosal layer. Cytokine expression moving forward, and our esteemed colleague Peter wrote the JAMA editorial on this and talked about this turning the pathogenesis inside out, from acid on the roof to it's really the basement. So as we start to talk about esophageal diseases, this comes from a recent book, and I've taken this just as a snapshot, not to show you all the differences here, but just to highlight the differences of bacterial changes in GERD and Barrett's and these other diseases as it relates to up or down, microbial footprints, not necessarily absolute causality, but what we see. One comment about EOE. Clearly, there's a discriminant here, as you see in the salmon color, the EOE bacteria, and in the green, the non-EOE, and a heat map here showing really a discriminant function classification error that's quite striking, only 8%. Just one word about about carcinomas, and it's clearly very common in the U.S., and certainly pathogenesis we think is environmental. Mechanistically, it's tied to biome, particular for P. gingivalis and squamous cell, and also the gram-negative shifts that we see in adenocarcinoma. So where do we go with this information? What do I like you to take home? Well, begin to recognize that the oral cavity is a significant microbial reservoir. Oral health and periodontal disease have local effect, but more far-reaching systemic effects. And recognizably, this gum-gut axis is real. And there are new paradigm shifts. I believe for us as gastroenterologists, we sit here and think about things like, what's your stool frequency? Did you have blood with your bowel movements? How about, did you see your dentist? Do you brush your teeth regularly? Do you floss regularly? We know there's risk reduction for oral hygiene, but we can take from today's discussion, hopefully, to recognize it's far way beyond that. And as much as we ascribe and aspire to be better gastroenterologists, let's take a pause. Maybe we should be better dentists as well. Let's take a trip and look at this also in the esophagus, moving from A to B, acid to bacteria. Not all causality, but I'll leave you with some of this just makes a lot of sense. And it's part of this making sense, it comes with wisdom. And with that, I'll leave you with the understanding of wisdom from a famous philosopher, Socrates. He said many years ago now, wonder is the beginning of wisdom. The key to true wisdom is recognizing that you know nothing. I think we're learning a lot, but we certainly know more than nothing. The goal of discussion today is not to provide you perhaps answers, but provocative information to drive great questions for you and apply these to your practice. And to stimulate that was really my ultimate goal. With that, I'll say thank you, but one final comment. Please brush regularly and floss daily. Thank you.
Fantastic, Dave. Thank you very much. Okay, I'm going to have Dr. Bang come up, our partner who is the most comprehensive endoscopist in our group, and we've charged her with the job of presenting some cases for this panel. So, G, welcome.
Thank you, Rob. Good morning, everyone. It's nice to see everyone so early this morning. So I have 2 cases for us to discuss. So the first patient is a 59-year-old female who has a history of achalasia and underwent Hellas myotomy in 2010, and then a poem actually in 2019. She was seen by one of my colleagues, Dr. Tran, who is our motility specialist, with chest pain and oral intake that was associated with nausea. She had no hematemesis, no weight loss, no dysphagia or regurgitation symptoms, and she was on omeprazole, BID, famotidine, amitriptyline, and gabapentin. So what is the next step in management? So the options we have are cardiology consult for possible cardiac etiology of chest pain, changing PPI from omeprazole to pantoprazole, perform esophageal impedance and pH monitoring, or lastly, esophageal manometry. Can I get feedback from the panel also? Yes, please.
Well, a cardiology consult is always a good idea when you get chest pain because you don't want to get caught with your pants down there. Pantoprazole, not a good drug. pH impedance measurement in somebody who is achalasia post 2 myotomies, going to be positive. Esophageal manometry, I'd do a flip study.
Very interesting. So she actually had all of those tests done, actually. So starting with a cardiac evaluation, she had no cardiac etiology of her chest pain. She had EGD with Bravo, and the EGD showed that she had no esophagitis, no Barrett. She did have a hiatal hernia and evidence of acid reflux. She had an esophageal manometry, which showed absent peristalsis, but no evidence of residual achalasia. That was also confirmed on endoflip. So what would you do next? So surgery referral for fundoplication. Refer for transoral incisionless fundoplication. Continue PPI and or add sucralfate. Oh, please scan the QR code. Thank you. Peter, any inputs on what you would do next?
I think you would increase the PPI to twice daily reflexively in a case like this. I wouldn't use pantoprazole for the reasons I mentioned on the potency slide, but when you have post-treatment failure in achalasia, it's usually from reflux. That's just a given. It's not from residual achalasia. Usually it's from reflux. And I don't know the details of why this person had 2 myotomies done, but that's unusual. But if they had a Heller myotomy, they probably already had a fundoplication, so I'm not... You said a Hill grade 2 on endoscopy, that's kind of meaningless. It means it's loose. It means they had a myotomy, basically, but it's not saying they had a hiatal hernia. Your endoscopy didn't say anything about whether or not they had evidence of a fundoplication, did they?
They did, yeah.
They did. Yes?
Well, she had a Hill too, right? So probably the fundoplication was gone.
That's not necessarily, Rob. I mean, a Hill 2, as I understand it, simply means that it's lax around the endoscope.
So probably not effective.
Yeah.
Can I let me make a couple comments? Is mine on?
Yeah.
One, not to pick on the sucralfate choice, but I just saw a paper that looked at the value of sucralfate. It's a $400 million drug even still in this country, and it's never been shown to work really in anything, certainly in the esophagus. And it's just amazing. If you use it, I always tell my patients if they want, if they come in with it, to get the tablets and dissolve it, because the liquid is so ridiculously expensive.
No, it's good for people who have diarrhea.
How do you take it? Which approach? The second point is, what I would do in this patient, I would get ahead of the bed elevation. I'd probably get a bed wedge. This patient's probably having nocturnal reflux, I suspect, on their pH monitoring, because they've got 2 myotomies. They don't have any type of really protection from their Hill. And I wonder about some of this hypersensitization Peter talked about, because I always take a sleep history in my patients with reflux. And in somebody that's maybe having ongoing symptoms, even if it's acid related or it's non-acid related, your sensory thresholds all go down. So anybody that's having nocturnal problems here, and maybe nocturnal regurgitation in an achalasia patient, they can have a cognitive or a non-cognitive awakening. If you have a non-cognitive awakening, you have a sensory arousal, but it's still disruptive from the normal transitions through sleep. So you don't have to just go to REM to get restful sleep and restorative sleep. It's transitions and smooth transitions. If you have a cognitive awakening, you can remember that, or B, you can forget it because sleep also has an amnestic effect. So this patient may not even tell you that they had problems with sleep at night from regurg or whatever, or acid or non-acid reflux. So I would take a really good history, and my discriminant question for patients is, how do you, your next day function? So when you get up in the morning, are you relaxed, are you ready to go, or do you have to drag yourself up? Early fatigability, restlessness, anxiety, raise your hand if you have all those things, but nonetheless, those are things that make somebody more sensitive to anything in the esophagus. Ronnie Foss showed this a number of years ago where he did Bernstein testing and looked at shock response, and the sensitivities are all much less in patients that had poor sleep the night before. So I would just take this a little step further.
So Pete, you've got some experience. I mean, the audience is favoring the TIF, and you've certainly got experience on this. They've got a Hill 2 kind of anatomy. They've already had a fundoplication, so they've already had surgery in that area. They've got evidence of reflux. You already said that people with achalasia who have ongoing symptoms probably have reflux. Why are you not talking about TIF?
First, do no harm.
Does TIF do harm?
It can. I mean, when you have achalasia and absent contractility, any added outflow obstruction is potentially problematic. And I would be very careful. I wouldn't be very careful. I wouldn't do it. I can manage reflux in these people pretty well using the type of things that Dave was just talking about. Head to bed elevation, you maximize PPI therapy, throw in a tricyclic if you think there's an element of hypersensitivity there. But I wouldn't do a third procedural intervention.
What about, I like alginates if you can find true alginates in this country anymore, but that
Amazon, you can get the real stuff on Amazon.
It's one of my favorites for somebody that again, a nighttime administration for alginates may give you something as a mechanical raft a little bit there that helps.
Peter, can you also talk a little bit about the new classification system that was developed by AFS? Is this something that we should be really educating our audience about?
Yeah, but I didn't have that talk with me. But yes, so the American Foregut Society has kind of revised this Hill classification into AFS classification, which is also 1 through 4, but looks at the hiatus in terms of presence or absence of a flap valve, the diameter of the hiatus when you fully insufflate the stomach to see whether or not there is a defect there. And this person's going to have a defect because they had dissection surgery. Basically, they had a Heller myotomy done. And you look at the axial length of herniation with full insufflation. And then you score it 1 to 4 based on the worst of those things. So if the hiatal aperture is 3 endoscopes, that's the worst thing. If you have 3 centimeters of axial herniation, that's the worst thing. It's much more meaningful than Hill because Hill doesn't tell you anything about hiatal hernia. All it tells you about is the flap valve.
Okay, G, so what happened?
So Peter's going to be a little disappointed. The patient had TIF. And you're right, so she's continued to have persistent symptoms, ongoing chest pain with oral intake. And so she had another EGD with Bravo, and it shows persistent acid reflux.
Whoa. What did it show? So you did a Bravo, which means you did either a 2-day or a 4-day study. What did it show? Of course they have some acid reflux. Is it 6%? Is it 20%? Is it 1 day abnormal? Is it every day abnormal? This is the way one should score a Bravo study.
Yeah, I don't have the full data on the full results because it was done at a different institution. We just know it was positive.
I think this is kind of a persistent theme of mine lately. Tests are not dichotomous. They're not yes, no. They're all on a spectrum. They can be a little abnormal, they can be very abnormal. Somebody with achalasia is always going to be abnormal with respect.
So explain what that means in terms of your decision making. So let's just say for example, that it was a huge amount of reflux versus
Well,
it
this
was
is
some
actually,
reflux, but not very much.
whereas usually you basically say in somebody with unproven reflux, you should always be doing the test off anti-secretory medication. This is an instance where you should probably be doing it on anti-secretory medication, because what you're really asking is whether or not you have adequately suppressed acid secretion in the stomach to the extent that it is possible to suppress it. And, you know, I mean, these days that's vonoprazan, but yes. This, by the way, is one of the target populations to use vonoprazan, is treated achalasics.
Okay.
So this is clearly a very, difficult, challenging case, I think, kind of, obviously, as we discussed with the panel, compounded with the fact that she has an underlying motility disorder, had undergone 2 prior myotomies, as Peter's pointed out. And so I think we wanted to kind of get a good input from the panel on, first of all, just kind of starting with the baseline, how to best manage GERD in achalasia patients who have undergone prior myotomies. And then with this patient with ongoing symptoms, with a significant surgical history, who already, we think, optimally medically treated and has failed endoscopic therapy as well. So that would be kind of, I think, helpful for this very complicated case.
Let's do one more.
Did you try vonoprazan?
Say that again?
Did you try vonoprazan?
I don't think so.
Try it.
Okay. I'll let Dr. Chan know. Okay. All right. Our second case is a little more straightforward. So this is a 73-year-old who had long-standing acid reflux. He had a C2M5 Barrett's esophagus with 2 nodule/mass lesions in the esophagus. Initially was referred as just the 1 nodule, but as you can see on MBI, there is another small nodular component right here, along with this obvious mass here. So this should be more straightforward. Please scan the QR code. What will be the next step in management? RFA, EMR, ESD. Can I throw the question to the panel first? What would you do? Sachin?
Yeah, I think you have the option of doing mucosal resection or submucosal dissection, but given the fact that I saw that there was a fairly large area, I couldn't see the NBI features, but given the large size, if there's any concern for submucosal invasion, our practice has now evolved to performing ESD for those patients, recognizing that the vast majority of visible lesions you can remove with endoscopic mucosal resection using the multiband mucosectomy technique. And I will just add that this was addressed in great detail in the most recent guideline document, where we've provided criteria on when you should be performing ESD. This would potentially be one of those patients, large size lesion, concern for submucosally invasive cancer, Paris 2C or 3 lesions. Those are the patients that you would consider ESD for.
Sachin, would there be a role for EUS before you did any of these?
No, not really, because EUS does such a lousy job in differentiating between T1A versus T1B disease. I would not do any EUS. Having said that, at some point, I think it's advisable that you perform an EUS to rule out nodal disease if you made a diagnosis of T1A or T1B, because the risk of nodal disease in patients with T1A cancer is up to 2%, and of course much higher for patients with T1B disease, which can be as high as 20%, depending on the depth of invasion and other characteristics such as lymphovascular invasion and whether you see well-differentiated versus moderate or high or poorly differentiated cancer.
I think you can't do EUS on a pedunculated lesion. You can't get perpendicular access and really look at invasion. So the pedunculated lesion that she showed is not worthwhile. The problem with nodal disease in Barrett's is just that the inflammation itself can create some nodal disease, and so you pretty much have to biopsy it, and biopsying nodes in a background of high-grade dysplasia, carcinoma, you don't really know where the needle is going. So there are some problems with EUS in that circumstance.
And same point for doing a PET scan. Do not do a PET scan immediately after you've performed a resection, because obviously the PET scan will show increased activity at the site of your resection and make assessment really hard.
Okay, G, what was done?
So we did an ESD on this patient for the reasons that Sachin had mentioned. It was a large area. We were concerned of malignancy, especially in the larger lesion that we had encountered. Also, we wanted to make sure that we didn't leave any nodular areas in between those two masses behind, because the mucosa in between those two nodular areas also looked significantly abnormal. So I'll just speed this up a little bit because it's just a lot of cutting, and this is what we did, about 60% resected. And this is the specimen afterwards. And the pathology actually ended up being intramucosal adenocarcinoma arising within high-grade dysplasia with stages T1A tumor with no lymphovascular invasion and margins negative. So this is an ESG guideline for managing Barrett's esophagus. I like it because it's very simple, straightforward, it has a flow diagram and very easy to follow. But basically the ESG recommends ESD actually for Paris 1S, 2C, or lesions that you suspect be malignant that's greater than 2 centimeters, or if you suspect significant fibrosis or scarring. And this is just a retrospective study from the Netherlands, which basically shows their success rate for patients with early esophageal cancer who have undergone ESD. And as you can see, patients who underwent en bloc and R0 resection had no neoplasia in 99% of cases on follow-up. Patients with en bloc and R1 resection had no neoplasia in 71%. So endoscopic therapy seems to be very effective for these early cancers in the setting of Barrett's. Thank you.
Okay, well, I want to thank our panel. Fantastic discussions. Thank you, G, for the cases. We now are going to take a break.